Hello, am I audible? Dr. Akash, Dr. Ashish,
Yes,
am I
yes,
audible?
sir. Yes, sir. You're audible.
Thank you, thank you.
Hello, 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 hello.
Hello, good morning, sir.
Can you hear me, no?
Yes, sir, you're audible.
ठीक, done. Thank you.
Good morning, everyone. Kindly wait for 2 more minutes. We'll be starting.
Good morning, sir. Sir, all the speakers have joined. Could we start the session? Good morning, everyone, and a very warm welcome to the 10th edition of Mental Health Dialogue. On behalf of NMHS2 team, myself, Dr. Divya, would extend my greetings to all the participants and distinguished speakers who all have joined us today. So once again, a welcome to the 10th edition of Mental Health Dialogues. As we all know, NMHS2 is a nationwide community survey that helps us to understand the current state of mental health and reaching every state and union territory in the country. And at the heart of this effort is mental health system assessment, which gives us the framework to understand where mental health stands and help us to evaluate how to make services more responsive. As a part of this effort, Mental Health Dialogue is more than just a meeting. It's a platform for meaningful exchange where researchers, practitioners, policymakers, and advocates come together to share their experiences, ideas, and solutions. Most importantly, it's a space to broaden our reach and strengthen our collective ability to improve public mental health services and support throughout the country. So let's use this opportunity to connect, collaborate, and inspire each other towards a healthier future. With that, let us now move to the theme of today's dialogue, that is digital applications for mental health and well-being. So, I have the pleasure of inviting Dr. Prachit R., who is Associate Professor in the Department of Epidemiology, NIMHANS, and Dr. Lata K., who is Associate Professor in Department of Mental Health Education, to moderate the sessions and introduce the distinguished speakers and chair for the session. Over to you, sir.
So thank you, Dr. Divya. So once again, a very good morning to one and all. And today, as we all know, we come together to explore how digital applications transform mental health and well-being. So as Dr. Divya rightly said, this mental health dialogue platform brings together various experts, stakeholders, and innovators to discuss certain practical evidence-based measures through which technology can bridge gaps in access and to enhance early intervention and support recovery. So through tools such as mood tracking, stress management, CBT-based exercises, digital solutions, we are attempting to make mental health care more accessible, affordable, and stigma-free. So this session on role of digital applications in mental health and well-being is an opportunity to share insights, showcase impactful initiatives, and inspire collaborative efforts to strengthen public mental health in the digital era. So we have two sessions. The session one is titled Leveraging Digital Technology and Mental Health Care. And we have several distinguished speakers who are a part of this particular dialogue. And we have Dr. T.K. Srikanth, who is a professor of practice in computer science and head of the eHealth Research Center at IIT Bengaluru, who will be chairing this entire mental health dialogue on digital applications for mental health and well-being. The speakers for the first session on leveraging digital technology in mental health care are Professor Ian Hickey, who is a professor of psychiatry and co-director of health and policy, Brain and Mind Center, University of Sydney, and Dr. Seema Mehrotra, professor of clinical psychology, NIMHANS, and Dr. Prabhat Chand, professor and head department of Center for Addiction Medicine at NIMHANS. So we welcome all the chairpersons and the speakers to this particular session. So I would like to hand over to my colleague, Dr. Lata K., Associate Professor in the Department of Mental Health Education, NIMHANS, and I request her to please introduce the chair for the session, Dr. T.K. Srikanth.
Good morning, one and all. So it is a privilege to introduce Dr. T.K. Srikanth. Dr. Srikanth is a professor of practice in computer science at IIIT Bangalore. His research interests are in systems for the management and analysis of healthcare data, data privacy, geometric modeling, and computer graphics. He heads the eHealth Research Center at IIIT-B, and he is actively associated with multiple collaborative research projects in healthcare, specifically on digital interventions around mental health. Prior to joining IIIT-B, he had extensive experience in software industry in India and in the US, in mobile and multimedia technologies, and in geometric modeling for geophysical applications. He has a PhD in computer science from Cornell University and a BTech in mechanical engineering from IIT Madras. So, welcome, sir. And it is an honor to have you as the chairperson for today's session one.
Thank you, Dr. Lata. Srikanth, sir, we request you to please give your opening remarks.
Thank you, Dr. Prachit, and thank you to all the organizers for setting up this. This is a wonderful platform, as you mentioned, for bringing together some leading experts, both practitioners and researchers, in this very important area of how digital technologies can help improve healthcare services and particularly mental health services. So I really look forward to this exciting and informative session that we'll all have. We have some of the best experts in this. So I will hand it back to the moderator so they can start introducing the actual speakers and move on with the presentation. Thank you.
Thank you, sir, for those remarks. So now we have session one on leveraging digital technology in mental health care. So a humble request to the speakers to please keep your talk to 15 minutes so that we can stay on schedule. So it's indeed an honor for us to have amongst us Professor Ian Hickey, who's a professor of psychiatry and the co-director of Health and Policy, Brain and Mind Center, University of Sydney, Australia. Professor Hickey has led major public health and health service development projects in Australia, particularly focusing on early intervention for youth with depression, suicidal thoughts and behaviors, and complex mood disorders. He is very active in the development through co-design, implementation, and continuous evaluation of new health information and personal monitoring technologies. And so he has several publications and projects to his credit. So we are very honored to have you with us, sir. So over to you for your talk.
Great. So hopefully the sound is now coming through. I'll just check with you in terms of I sent some slides through, whether you had them at those end or do you want me to run them from here?
Just a second, sir. We'll be sharing the screen.
Yeah, we'd be sharing it from our end.
Okay. Okay, so it's a great pleasure to join you this afternoon from Sydney, and I hope it's an equally pleasant morning in Bengaluru this morning as it is here, as just we have our spring just starting. And this opportunity to share with you, and particularly in the environment in which you work. I mean, we obviously in Australia feel we are challenged by the increasing demand for mental health services, particularly amongst young people, but our limited capacity to supply that. However, living in the digital age, we do think there's a real opportunity to start to meet that demand early in the course of illness and more effectively. So I'd like to make some general comments about the challenges and then move on to our particular experiences in the youth mental health area. So in terms of running the slides, so I'll just say the next slide. Are you running the slides or can I run the slides myself? There we go. Just to say, I'll tease out some particular issues where I'm associated with one particular company in this particular technology. So the next slide. Obviously, we face a huge challenge globally in the demand for mental health services, particularly amongst younger people in younger cohorts and those related to aging and dementia. And the demand worldwide will continue to outstrip supply, and this gap will grow. And unless we think about things differently and how health workforces operate, unfortunately, that gap will grow and the equity associated with that work will grow. Where we have really skilled workforces, their availability will be limited and young people will be most affected. So the growth in demand and the growth in real incidence of mental health problems is a worldwide phenomenon across all developing countries as well as developed countries. Next slide, please. So we have real challenge here. One is to just keep talking about access. And we've been doing this in Australia for about 25 years, get more people in. But in addition to access, we have to talk about what we do when we actually come into contact with people. Increasingly, technology will allow us to be in contact with people in need, but will it help us to deliver quality services? Will it help us to actually make sure that people get better, that it's inclusive, that it's person-centered, that it's relevant, that it doesn't just create more activity in our area, it actually delivers better lives. And that dual-headed, that dual-faced problem, I'd suggest, of access and quality is a real challenge for the e-mental health area as it is for mental health services. Next slide, please. So there's a big technology issue. Most people, when they talk about technology, think we're talking about very simple technology, simple apps, simple medical records, simple kind of archival documents. They don't really think about the potential in technology, the way technologies are rapidly developing. Of course, with the discussion worldwide of the impact of AI, people are even more concerned about what new technologies can really do. But we in the field need to be smart about how we train those technologies, how we use those technologies, and importantly in the R&D sense, how we evaluate those technologies. There is the issue also of engagement, how we co-design those technologies to be most appropriate to people's needs in the settings in which we work. Next slide, please. Okay, so I want to talk about three kind of levels of thing here. How do we actually provide information about mental health care? How do we get things out there? How have they been? And to say they've been rather static is to be rather polite. You know, I myself continue to still write books and produce information things and do stuff that is extremely limited and static in how it describes the areas. Of course, over the last 20 years, we've seen lots of examples increasingly of web-based information that provides good resources, but is rather one way in the way that it kind of operates. What we're looking for increasingly is how not only does information go out, but how might people use that information immediately to set goals, to manage actively through good self-care systems, where they're website-based or they're app-based, for common disorders, anxiety, mood, behavioral activation, sleep-wake cycles, eating, etc. Increasingly, of course, as the AI world develops, it's rapidly becoming not just a two-way linear type process, but one that increasingly personalizes itself around the individual and learns about the individual over time. This itself is a major kind of development and one that is rapidly happening. Since I was in India and in Bengaluru a year ago, that remarkable things have happened in that 1 year period. Things are happening in 3 month turnarounds here. And we need to be actively involved in how we take what we've already learnt in many of these and make use of new AI structures. What are the databases for that? How are those trained? Are they relevant to the populations we work with? And the third area I think is run that remains challenging. How do we bring tools into clinical care and create new health roles that at one level promote measurement, actually track what is happening? I say as a clinician all the time, I'm less interested, or not really interested at all much, in those people who get well. I'm interested in those who don't get well or get worse, despite having moved into our care systems. And how quickly can we respond and understand them, characterize their difficulties to deliver examples. We have a lot of examples in Australia developing that combine various aspects of clinical care with digitally based care and with measurement-based tools to try and make our health systems more efficient. So I want to run through some examples of just various levels of these different types of technologies that are increasingly part of our worlds. Next slide, please. And we might need to do this. So we've had national awareness campaigns, for example, Beyond Blue in Australia around common forms of depression. I was associated with setting up more than 20 years ago now, which have been pushing information in one direction out to people, and they contain good information. The good part of that is they're widely associated and promoted out directly to publics in need. Next slide, please. We have things that are more specialized in the depression area and try to combine this with clinical things. So Black Dog is one of our examples of a clinical-based service for better assessment of specialist depression that combines a lot of that information with what also to do in terms of exercise, in terms of tracking, in terms of self-report. Next slide, please. We have ones that are focused specifically in the youth area, led very famously by Pat McGorry, our Australian of the Year, and very famous in the early psychosis area, that try to take information out to a particular target audience, in this case, more suited to young people rather than the rest of the audience, trying to connect to the groups that would be most likely, trying to present their other products. One of their own products, for example, known as Most, tries to combine peer and social therapies with those particular youth audience. So linking to an organization that's high trust, that's well understood, but trying to target their information and their services more specifically to the age group around the ages of onset. Next slide, please. Head to Health is our government example of trying to find ways through our health agencies of government, trying to help people into the right parts of services, how to find resources, not just assume that practitioners will know or communities will know, trying to make it clearer what pathways to care really do exist and how you might be able to access those in more meaningful ways. Next slide, please. Increasingly, of course, we see more self-management and therapist-guided type tools, how to assist people to start to manage their problems either on their own or in association with particular tools for cognitive behavioral therapy, for management, linked again in our world. I guess we're kind of promoting linked again to reputable university sources, credible sources, services, making it clear who takes responsibility for these. So the self-management isn't just simply purchase it from an organization. Where might you go? And the extent to which you can self-direct, or you may require increasing assistance from a therapist or a guide. We've been associated with John Touros in Harvard University of using what we call digital navigators, having people who are not health professionals who actually assist people to use the technology in appropriate ways, putting them information, understand how the technology can work. It's not that easy to use a lot of the newer effective technologies simply on your own. Next slide, please. Another example where the community situation, we've been lucky in Australia to have an organisation called Reach Out, which for over 25 years now has been connecting particularly with young men and young people in trouble before they need clinical care in a different kind of way, not talking about diagnoses, but talking about having a tough time or in periods that are stressful, encouraging community and peer support along with better information and pathways to community care. But ever since it started, trying to be where young people are, not assuming that they will simply reach out to us when they are in trouble. Next slide, please. We've actually, of course, in our national primary care framework, been lucky in Australia to set up over the last 20 years, particular new primary care centres, Headspace. But Headspace has its own e-Headspace. It has its own out of hours, on contact, online series of connections. The attempt to scale, the attempt to actually provide clinical support out well beyond the bricks and mortar centres, but clearly associated with a well-articulated clinical program. Next slide, please. We have and have had for a long time really the development. Mood Gym is one of the oldest examples of CBT online in Australia, developed by Helen Christensen and colleagues at Australian National University. Now, it has more than a 20-year pedigree. There's nothing new about doing CBT online. CBT online, for those who benefit from CBT, is very effective. The issues is how do you better engage? How do you better personalise? In what series of ways could we make it more accessible and be clear that it was organising itself more around people's needs and their particular cognitive or emotional structures, rather than being rather preset and formulaic. However, the demand for such services has always been large and is growing rapidly. Next slide, please. An example of a really well moderated clinical service, one called MindSpot in Australia, run by Nick Titoff and colleagues, around really developing a clinical service, much more assessment as people come into that service, monitoring through the online service, and then trying to find the outcome. Much like the talking therapies in the UK and elsewhere, trying to use things in ways that are better suited to particular populations by trying to direct and stream the service that's most relevant, but strongly evaluating who's likely to benefit from that service and who's not likely to benefit. More intensive, less scalable, but quite specifically directed at the quality of the service that is delivered. Next slide, please. I'm personally associated with measurement-based care systems. The one we've spun off in Australia called Innerwell has both a self-care aspect, helping people to focus on things like sleep-wake cycles, psychosocial functioning, social networks, while also then being linked specifically to clinical platforms or clinical tracking once people come into clinical services. Next slide, please. So that the self-care aspects of Innerwell have included these particular aspects, the ones I'm particularly tend to be fussed about in sleep-wake cycle, in social connection, physical activity, but encouraging very strong goal setting and activities in the preclinical space, but also while continuing in clinical care. Next slide, please. The next slide. Yeah, so the two that I'll highlight are those two. When we move into the e-clinic examples, we're trying to produce dashboards that clinicians can use alongside their particular clinical services and creating tags and warnings, filling out the clinical record. Now, one of the things about this is a lot of the information being put in by patients, by clients, before they see clinicians, so that areas are highlighted for clinicians to focus on. Clinicians not spending all of their time collecting information, but actually using information. Next slide, please. Can we go to the next slide, please? We stuck? There we go. Whoops. Okay, yeah, so sharing plans, one of the things about the clinical support world is starting to actually share that, to encourage shared planning. One of these tool ideas in the clinics is using more information that people can put in to help people build share plans, clinical plans they can work with people, not just simply directing, but being more interactive in the way that we deal with the clienteles that we have to manage better over time, and increasingly in an asynchronous fashion. So not at the same time necessarily you're seeing the person, but at times when you're actually able to do this, at times that don't require people to come to clinics continuously. Next slide, please. Okay, increasingly in this world, of course, it isn't just what people will put in as self-report, increasingly how much you'll use personal devices that come in and how much you'll use those during critical periods in people's lives, how much you'll use mood trackers, sleep trackers, physical activities, what people are doing socially. So the world of wearables and monitoring to bring more personal data in alongside what is being recorded in traditional dashboards is part of this very important movement. Next slide, please. So the models that we have of more comprehensive care have many elements of multidimensional element. But if you highlight the next slide, hopefully a red box will come up now. Next slide. Yeah, is to say a lot of the things we want to do in terms of better care will depend on having appropriate digital platforms to support the complex assessment and ongoing monitoring in real time of outcomes in people that we care about. And we've written this up extensively within the Medical Journal of Australia. Next slide, please. So for us, there's a combination of personalisation of care and combining that in real time with measurement to deliver the right care the first time in areas where you live, facilitated by technology. Next slide, please. Right where things are going now in our work is to take where we've been and combine it with the data that comes back to combine new predictive AI tools, trying to tell which trajectories are people on so that we can make better predictions about their future paths, alongside with the causal AI to try and understand at the individual level what factors are driving illness course within the individuals that we are seeing. Next slide, please. That'll be enhanced by having increasing digital phenotypes. So more information coming back that we feed in, some of which is known to the person, but many aspects of their physiological function or their cognitive function, which isn't known, encouraging people to continue to allow us to know more about passively connected phenotypes or specifically connected. So we have much more individual data. We learn much better about individuals over time as a consequence of the technology. Next slide, please. And that will be both passive and wearable, leading into databases. The issue about the databases is using the individual levels, not just to learn about the person, but to learn much more about the groups that we're seeing, young people living in particular environments, different subgroups of people, so that we're also learning continuously from the data sources. So we want more young people to participate, but as they participate, we learn more. Our potential to use those databases to train our AI models better is really critical. So a big issue for us is not simply saying AI will happen out in the rest of the world. What will we train that AI on, and growing the databases that are specifically relevant to our work. Next slide, please. That'll include more sophisticated measures of things like sleep-wake cycle and circadian systems. As we have more systems, we'll learn more at a specific physiological level, as well as at a cognitive and phenotypic level. Next slide, please. The particular tool that we're working on at the moment, we call MIA, the Mental Health Intelligence Assistant, is really designed to take this one step further, to continuously expand and use AI at scale, and then use a tool that other people will be able to interact with much, much more easily, question and interpret, to continuously build up a much better picture of themselves, where the AI is learning about them, but it's also being developed and we are training it on our own extensive knowledge banks and expert opinion. Next slide, please. We're actually got to address increasingly in all of these digital tools the key issue of how to get people to engage. We think that is by being smarter in the assessment, moving to personalisation quicker, providing better information back to people that influences in real time clinical decision making. Next slide, please. When we look at this, it's not only more effective in terms of healthcare. If you go to the next slide, it's cost effective. If you go to the next slide, yeah, just to highlight, it doesn't only work better, it's also, when you face reality of the financial constraints, workforce cost, a better way to do things, reduce disengagement, increase the improvement of services. So I point out when people say it's costly to invest in technology, at the end of the day, it is much more effective use of resources than our traditional approaches. Next slide, please. We're almost at the end here. One of the other issues, and I think it's particularly relevant to the Indian environment, is the use by all sorts of different workforces. If you just do things at the moment and you don't have additional tools, only a small number of people have sufficient expertise to deliver better care. If you combine that with effective tools, next slide, please. What we are aiming to do is lift many workers to levels of expertise by putting tools in their hands that will assess them to better assess and better track care. And I think in the environments like India and the developing world, this is a critical initiative. Many, many more people will be able to participate in the delivery of effective care. Next slide, please. Okay, we've got to be careful about safety, security, working with people to co-design to make sure people trust us to work safely online. A lot of pushback at the moment about whether you can trust such systems and will they keep people safe. Next slide, please. Okay, there are lots of opportunities here, I think, for all of us. There are issues around standards, there are issues about deployment. We are really keen in this particular case, and I'm going to say this to people directly, to support regional partnerships to develop systems that are fit for purpose in particular settings. It's not just a matter of just importing the tools from elsewhere in the world or bringing them to your population. It's about working with people to make them work locally. Next slide, please. And just to get to the end, this work isn't just done by me. It's done by a large set of people, mainly young people working in the area. So thank you for your attention.
Thank you very much, Professor Hickey. That was an incredible talk. It was quite comprehensive, and you managed to cover so much information in a short period of time. Just maybe my takeaways from this, or what I picked up, were I think you highlighted the importance that there is and is going to be a supply-demand gap for the near future, and technology is going to be one key ingredient to help us bring down that gap or solve that. But we have to be smart about use of technologies, find the right tools, especially the emerging technologies, and how do we integrate all these different kinds of data that's potentially there, integrate them, and then use AI and other analytics to provide better personalized care in an integrated manner, synchronous, asynchronous, the whole bunch of possibilities. Really nice to see you covering all that. And also the other very important point you brought up is that there's always going to be a skill gap across the healthcare workforce. There's no way we're going to have a uniform workforce, and proper use of AI and related tools can help reduce that gap or actually improve it. And so I think this is very good. I think you gave a wonderful tour, and very happy, very impressed to see the kind of work that you're all doing there, and look forward to hearing more from you. Thank you very much.
Thank you.
That's it. Maybe we can hand back.
Thank you, Professor Ian. We are really grateful for that excellent talk on digital apps in public mental health. So collaborations to make mental health care more inclusive and accessible to all. So please post your questions in the chat box. We will have a question and answer session at the end of session 1 after the 3 talks conclude. So moving on, the next talk is on digital interventions for mental health care and suicide prevention. And our speaker is Dr. Seema Merhotra. So Dr. Seema Merhotra is a professor in the Department of Clinical Psychology at NIMHANS, Bangalore. She trained as a clinical psychologist at NIMHANS and earned her PhD in the year 1996 from Nagpur University, focusing on the intersection of psycho-oncology and well-being. She has more than 22 years of clinical teaching and research experience, and including nearly a decade at Kasturba Medical College, Manipal, before joining NIMHANS in the year 2002. At NIMHANS, she heads the clinical psychology services for an adult psychiatry unit, coordinates the positive psychology unit, and runs Flourish, a positive mental health clinic at the NIMHANS Center for Wellbeing. Her research spans mental health promotion, positive psychology, adaptation to major life events, self-development, and emotional regulation. She has developed preventive interventions for young adults, supervised over 2 dozens of MPhil and PhD scholars, and led several research projects funded by reputed funding agencies like the ICMR, the ICSSR, and CSIR. Her work is widely published in national and international journals. Over to you, ma'am.
Thank you. Thank you, Dr. Prachot. May I share the slides, please? Can I share
Yes,
the
ma'am.
slides?
Yes, ma'am.
Are these visible? Yeah.
Yes, ma'am, it's visible.
Thank you. Thank you so much. Thank you, first of all, to NMHS team for giving us this opportunity to present. Professor Yan has, beautifully covered the entire landscape of digital tools for mental health care. So my talk would be a little more limited in scope and more focused on our observations and experiences from this end. I would like to be focusing on barriers to bridges, how digital pathways can open doors to opportunities for clients and for healthcare professionals. Basically, we are looking at, or I'm going to be talking more about the clients or individuals who are in distress and in need of help, whom we don't see in hospitals and clinics, as well as individuals who do come to our clinics and mainstream services, but we are not able to do enough. We are not able to do all that we can do in terms of access to psychological services, counselings, and therapy. So we are going to be talking about these two groups of populations. I will not spend much time on this. Is the slide transition happening?
Yes, ma'am, it's happening.
Yeah, thank you. So I won't spend a lot of time on this. Basically, we all know that there is a huge treatment gap of more than 80% in India for common mental health concerns, in fact, for any mental morbidity. It is also very well established that psychological interventions are the first line of treatments for common mental disorders. They are efficacious, but at the same time not accessible to a large number of population in the country. It is also well known that subthreshold symptoms, subclinical symptoms of depression and anxiety are also associated with distress and difficulties in functioning. In fact, we look at global literature on youth, more than 29% of youth may have subclinical symptoms which affect their functioning and have implications for future trajectories vis-a-vis quality of life, and hence the need for a multi-pronged approach to increase access. Now, what is also very well known and established globally is merely making mental health facilities available, and in fact, having more mental health professionals available by itself is unlikely to be sufficient to bridge the treatment gap, because we need to make these services more accessible and not just more available. Also, there is enough to say, including WHO recommendations on pyramid of mental health care mix of services, that we need to also work on increasing the capacities for communities to take care of their own mental health needs, that is self-care and peer support, as well as to not just work on enhancing or reducing supply side barriers, but reduce the demand side barriers, that is by breaking mental and social barriers to help seeking from professionals when that is required. So where do digital pathways come in this context? That obviously they have a good potential or scope for enhancing mental health literacy, reducing stigma, improving positive attitudes towards mental health in itself, which can then lead to early identification and intervention, community empowerment through strengthening self-help skills, particularly when mental health concerns are milder in nature, so they do not tax the healthcare systems, whereas enhancing motivation and self-efficacy in reaching out to professional help when needed, that is handling the demand side barriers so that more people who require professional help are able to reach out for such help. On all these counts, digital tools can provide important avenues and platforms. Also, in addition to this, for the mainstream services, digital tools could enable access to online support. I think Dr. Hickey was talking about it, facilitate symptom monitoring, support or supplement the professional help that we already provide if they are well integrated with mainstream services. Let me move on to observations and illustrations from some of our work. Let me start with giving an example of a review of apps, mental health apps for depression that we carried out way back in 2017. What we found of review of depression apps which are available for Indian users on Android platforms, that most of these apps were merely information provision or self-monitoring category. Almost all of them, a majority of them, were completely unguided self-care apps, which have its own potential for dangers while it has potential for scalability. Only 33% were interactive self-care apps, which we reviewed. Very importantly, these provided a very confusing array of options to users. Only less than 10% of them provided information within the app to the users as to what is the scope, when should this app be used or not used, or did not have any screening for suitability, which becomes a very, very critical element in a country like India with low mental health literacy. Only 12%, despite all these apps being for depression, only 12% had any guidance on managing suicidal thoughts or crisis, and only 1/3 included any content on when to step up from self-help to a higher intensity of intervention. It was in the background of some research of this kind that we evolved a website basically, and then subsequently an app called Pushti, that is practice and use self-help for depression. And we conducted, and this was done with support from ICMR and IIIT Bangalore, particularly Professor Shrikant was our navigator and the guide. We developed this app with almost close to zero funding for technology and design. So thanks to IIITB. The pilot trial on this app, which is basically, which involved structured self-help through Pushti with minimal telephonic support. So it is a minimally guided self-help app. That's the form in which it was tested. What we realized in the course of this trial, which involved participants from the community, that the typical users were young adults with undergraduate level of education, mild to moderate severity of depression, with impairments in functioning. Most importantly, what I want to highlight here is who were the seekers of this platform during the trial. Majority of them had never sought mental health help early. They were treatment naive. They were naive to use of mainstream services. 82%, despite having significant psychiatric symptoms in form of mild, moderate, or even severe depression, had not sought help for current problems. So this highlights that how an app like this was able to reach out to people who had never sought help earlier and who were actually at the point not so inclined to seek professional services in the mainstream. When we asked them about the reasons for preference, obviously the preference for using digital tools were preference for flexibility, time constraints, a need for autonomy, a sense of reliance on what I can do for myself, which comes as a very important element when we are looking at youth and young adults, the desire to learn to prevent problems in future. This was true for those who had sought help earlier, but wanted to do something more to learn self-help skills. Moreover, perceptions of one's own problems as being low in severity, that it's not severe enough for me to meet a mental health professional, and lack of easy access to services were some of the reasons cited by users in this trial. What were our key findings? We assessed an array of outcomes, both self and clinician rated, and we found statistically as well as clinically significant changes following 4 to 6 weeks of Pushti usage with minimal telephonic support with medium to large effect size. 75% shifted to lower severe category on depression. Gains were evident for after partial completion of the app sessions also. And gains remain stable at 2 months follow. And we did have back-end data on how the users perceive push-T and how they saw it as a ray of hope, how they found the structure and the guidance to be very useful. It could be the structured framework, the educative element, the motivational element, which is built in push-T, the tools for self-learning, and the minimal guidance and therapeutic relationship and awareness that there is some human support in the background were probably some of the mechanisms which might have resulted in the outcomes that we see. Now let's look at another exploration, which is through another very low intensity intervention, if I could say. It's about a tool which basically provides structured, standardized questionnaires on distress and well-being, and provides opportunities to receive feedback based on how people respond to those questionnaires. So our question was whether when such a tool is made available on a digital platform and pitched or positioned as a mental well-being tool, can it engage distressed, non-treatment seeking adults in mental health dialogues and conversations? So this was where Wellness Check was born with little small amount of funding from ICSSR. And we are redesigning this tool and should be made available soon in the near future. The pilot trial of this Wellness Check, again, I just want to highlight what we discovered. Who accessed the platform? It was a well-being tool. 58% were distressed adult, with a significant proportion being having moderate to severe symptoms. 70% with no exposure to mental health services. Only 12% were currently seeking help. And the severe distress subgroup was significantly ambivalent about seeking professional help in the near future. So again, this demonstrated that a simple platform like this could actually engage people who are otherwise not reaching out for services or help while they actually require the same. So the learnings we had from these initial trials were that the Indian adults, particularly in the urban Indian context with some level of formal education, have openness to use digital tools. It has potential to reach out to those in distress but not availing services. It has potential to result in significant drop in symptoms and improvement in functioning, and fine-tuning can improve adherence. Like the initial push-T trial, we found that the adherence rates or the engagement rates were of concern. We also conducted a smartphone intervention review, which was published in Current Opinions in Psychiatry. And one thing that got highlighted is that there are quite a few researched apps, particularly coming from developed nations. Very few of those researched apps are available to public in virtual stores. And those tools or apps which are available to public, majority of them fall under the non-researched category, so which actually indicates scope for further work. We also realized that a digital tool with minimal guidance and primary reliance on self-help has its limitations because it doesn't involve consistently working through the medium of professional relationship, which is a very important factor in influencing outcome and adherence. Conversation, dialogues, and narratives, very little scope for that. Uncovering past, very little scope for that. And a difficult, when people have difficult emotions rooted in past events or trauma, difficulties in processing difficult emotions in safe and real therapeutic presence. So it may be useful for such category of population and not for all. And that's where we moved on to create another version of push-T, from purely unguided to minimally guided to blended intervention. What are blended interventions? As you must be aware, these are interventions which combine internet or mobile-based self-help, structured self-help, with a few face-to-face sessions by a professional. The research globally suggests that blended approach can reduce cost, reduce clinician burden, increase their time to devote to other instances where there are more complexities and more clinical investment or time investment or human resource investment is needed. So blended interventions offer scope for improving therapeutic alliance, unlike minimally guided interventions. They can customize more to individual needs. Transfer of skills can be better and could remarkably improve adherence, as we saw later, and may be more suitable for those with greater severity of symptoms. So that is what brought us to Push T Plus, which is a blended intervention study that we conducted. It's a doctoral study which was completed successfully on treatment seekers. So it integrated structured self-help with 4 to 6 online sessions with the therapist in a clinical sample of persons with depression, majority of whom go without access to psychotherapy services. So face-to-face sessions focused on how to apply what they learned through the app, and therapeutic space was used to reinforce their efforts and enhance their motivation. What was found is it was again a pre-post follow-up single group open label study. It found that they were the Pushti Plus or the blended intervention program was effective in reducing depressive symptoms, improving functioning, had good acceptability and significant potential for scale, and dropout rates were much, much lower compared to minimally guided. That is about 23%. Then I move on to give you another illustration, which you will be hearing about more a little later, which is a more has a broader scope on common mental health concerns, unlike Pushti, which is focused on depression, and a more intensive uh, internet-based and mobile-based platform. MindNotes is a broader range platform. It's an application meant to support individuals in distress or those experiencing common mental health concerns to clarify, what am I going through? What's wrong? What is happening? Is it severe enough to require help? To help them engage in self-help modules, as well as, very importantly, to learn to break barriers to seek professional help. I think that is the USP of MindNotes, that it helps people on the fringe, at the margins of seeking, not seeking help, to gently nudge them or encourage them to seek professional help when it is appropriate. Preliminary evaluation of MindNotes, which was a short-term prospective study with 2 weeks of app exploration, has indicated that it is seen as easy to navigate, engaging. Moderate to high ratings were received on perceived usefulness, and very importantly, the extent to which these participants explored the app significantly predicted their improvement in help-seeking inclination, particularly in the subgroup who had significant common mental health concerns. Another platform which again attempts to build bridges between no help for people in distress to minimal help, pure support, and nudging them for professional help is the Let's Talk Life online moderated peer support platform, which involves trained youth volunteers who respond to queries which are posted anonymously, and the responses are moderated by experts. You will again hear more about it as we go along later in the sessions. I want to spend just a wee bit of time on another digital tool, which is not an intervention program like, say, Pushti. It is a help-seeking digital intervention platform. That is, its main goal is to enhance help-seeking amongst distressed young adults. So it is a low-intensity, scalable platform called Reach Out. Its aim is to educate and motivate distressed individuals to seek help. It was tested for effectiveness, feasibility, and acceptability in non-treatment seeking distressed young adults, both student and working adults. And what we found, that those distressed adults who had significant levels of distress for more than 3 months to 6 months, some of them up to 1 year, not seeking help, about 38% of them actually ended up seeking help at the end of the intervention. They had long-standing ambivalence and dilemmas. So it reduced help negation and perceived barriers to seeking, improved help seeking, and improved help seeking behaviors. More details are available on the papers that I've spoken about. This WhatsApp platform can be delivered by psychologists, counselors, health professionals, trainers, educators in university settings or workplace settings. It involves delivery of components through WhatsApp. A lot of it we are trying to automatize right now. It uses infographics, videos, and so on, in addition to a single session motivation interviewing call. So these are some of the components of reach out intervention. Facilitator's manual is available on Niman's website. Of course, when we use these digital tools, we have all these dilemmas as therapists and clinicians that we are not giving our best to the clients. We are not offering the best of us as therapists, not knowing how much the client is able to assimilate. We may feel that these apps are inadequate in handling complex issues, may offer non-contextualized solutions, particularly if these are completely unguided. And we always have worries and concerns whether clients will end up using these apps rather than reaching out for help. So this is where the apps need to be designed in a way that they can address these concerns, and we need to choose the apps wisely while we are, informing the clients what they can do and how they can do what they can do. But there are multiple sources of gratification that we as clinicians receive when we, step into this arena, because it makes us feel that taking one step forward, making access easier, can make a tangible difference in the lives of many people who have never ever sought professional help. And looking at the testimonies and the messages that we receive on our digital platform, it reinforces this belief in us that we are able to convey that people in distress need not struggle alone. It very importantly, these provide an opportunities to decrease the barriers to seek direct support and open up pathways to mainstream care. I was asked to touch upon suicide prevention and apps related to that. So I just want to highlight one of the reviews we conducted again on suicide prevention apps available to Indian users. I just want to highlight that there were a lot of issues that need to be fixed and resolved and addressed as app developers move forward. Approximately 1/3 of the apps, which were intended primarily for people at suicidal risk or were meant for suicide prevention, did not include any initial screening aspect. Only 1/3 of the apps included screening aspects, which means that people may not be guided sufficiently what else they need to do. It's very important when we are using an app for suicide prevention to educate individuals about the level of the risk and what are the options available. Similarly, most of the apps provided suicide helpline numbers, but only a few included motivational nudges to help people to reach a point, to reach out for help, or to even call those helplines. Merely providing helpline numbers many a times may not be efficient for clients in high distress. They need those motivational nudges. I would also take this opportunity to highlight about another project, which is a national health research project being carried out in India with 8 states collaboration, and the collaboration with government departments is ICMR multi-state implementation study, which involves various components such as formation of well-being teams in campuses, both school, pre-university and college campuses, training of leaders, teachers and youth, crisis response systems to be in place, as well as self-help resources. While we are attempting in near future to digitize some of these training modules, we already have the self-help resources on a platform called mywellbeingshelf.com, which again is self-help resources in digital medium for students from particularly in higher education, providing various kinds of information, hopefully in more and more languages in future. So on one hand, we have growing evidence based on mobile intervention, but shortage of studies on effectiveness implementation, shortage of studies on field reports of how these are deployed, how these can be integrated with mainstream services, particularly from low resource settings from countries like India. We have fewer research on stakeholder perspectives and factors that relate to user uptake and engagement in diverse cultures. As I said, a bulk of research is from developed nations still. So in this context, we are grateful to ICMR, which actually has funded a 5-year center for advanced research in digital interventions for mental health care. As part of that, we have just completed carrying out systematic review of mental health apps for Indian users using preset criteria and 5 search words. A total of 3,000 plus apps were downloaded and screened, with 792 eligible, which were shortlisted for detailed review. And finally, we have reviewed 350 apps which have undergone detailed review. What I want to highlight here for this audience is most apps have been developed in this review, have been developed by commercial organization. There is more and more involvement of academia and of researchers as well as mental health professionals in this field. 65% did not mention mental health professional involvement, while a few mentioned that in a very cursory sense. 11% of apps only mentioned research that has been done on the app itself. The pointers to seek professional help, that apps are not enough to reach out for professional help, were evident in 40% of the apps, but these were mostly in terms of disclaimers. This is not a substitute for professional help, something at that level alone. While nudges or motivation prompts to seek professional help when the app identifies that a person is in distress, high distress, were evident only in less than a quarter of the apps. Very few apps attempted to dispel common mental health myths, which again is a priority for apps which are serving the Indian population or population in the low resource settings. So in this CAR center, further studies are being implemented on MindNotes app, which I spoke about, the Let's Talk Live peer support forum, the Reach Out intervention, which is WhatsApp-based help-seeking improvement intervention, Pushti, as well as blended Pushti Plus intervention. And we look forward to those of you who may be interested to partner, collaborate, and contribute to the work of the center in one way or another. Please do feel free to write to us at car.icmr.nimhans@gmail.com. I want to end with this food for thought that based on all that we discussed, isn't there a need to broaden our attention to the entire continuum of mental health care for reducing treatment burden or treatment gap? Isn't that psychological intervention which are delivered beyond clinical settings may serve not just as low intensity interventions, but also as gateways to seek mainstream interventions? Is it not worth stepping out beyond our clinical and hospital walls? Are we doing that enough? Are we doing that often? Our gratitude to our funders, Indian Council of Medical Research, Microsoft India, which is helping us redesign Pushti, ICSSR for the initial wellness check, which we are again redesigning. Our immense gratitude to the technology partner, International Institute of Information Technology team, headed by Professor Shrikant, and the core members of the teams from all these projects I spoke to you about: Department of Psychiatry, Center for Public Health, Child and Adolescent Psychiatry, Mental Health Education, Biostatistics, Clinical Psychology departments at NIMHANS, and Department of Psychiatry, AIMS, New Delhi, which is our collaborator in the Center for Advanced Research. Thank you so much. Thank you.
Thank you, Dr. Seema. Wonderful to hear you as always, and the depth and the detail to which you've gone. I think the fact you highlighted the amount of research that's gone into understanding the apps that are there and what are the shortcomings and applicability is quite important. And I hope everybody has good takeaways from that. I mean, the need for a multi-pronged approach, and while the treatment gap is there and we'll always have that, I think the focus on really getting people to seek help seeking and breaking barriers, I think that's a constant focus you've had, and good to see that There are, as you put it, combining digital tools in a blended approach and actually using them as gateways to bringing people into the mainstream care, which is ultimately the need, especially in all places and especially in India. I think the other very important aspect that I think everyone should read up on is the gaps in the existing apps that are there, the shortcomings that are there, the limitations, and how there's so not enough research, or maybe how we should bring more responsibility into bear when producing such apps that are intended to give a holistic help for the users. So good to see all this work, and congratulations on all of this, and really look forward to continue.
Thank you.
Thank you, Dr. Prachit. Please take over.
Yeah, thank you, sir. Many thanks, ma'am, for your talk on digital interventions in mental health and particularly focusing on barriers to bridges. So it was both timely as well as thought-provoking, highlighting how technology and how this blended approach that you referred to may help people in distress and also save lives. So thank you, ma'am. So moving on, we have the next talk, which is on use of apps in supporting addiction prevention and recovery. And our speaker is Dr. Prabhat Chand. So Dr. Prabhat Chand is a psychiatrist with expertise in the area of addiction medicine. So he's made enormous attempts during his career of nearly 2 decades to integrate clinical care, academic research, and innovation to advance mental health care delivery. Sir currently serves as the officer in charge of the Center for Addiction Medicine at NIMHANS and has previously led the NIMHANS Digital Academy. He is the principal investigator for Quitline NIMHANS and also heads the Tobacco Cessation Clinic. A fellow of the ECO Institute in the United States of America, Dr. Prabhat has been instrumental in mentoring multiple digital academies across India, strengthening capacity building, telehealth, and mental health services nationwide. His areas of expertise include digital health, telehealth, capacity building, healthcare professional wellness, and medical education. And I would like to add here that he has developed several apps, including the addiction treatment app that has been shared in the chat. So, sir, I request you to kindly deliver the talk. Over to you.
Thanks, Prachit. Am I audible or is a problem?
Yeah, you are audible, sir.
Yeah. Switch my phone. The phone is ringing. Thanks, Dr. Girish and the NMHS team, who has been sort of asked me to talk about something that I mean, it's not my primary work I do, but still I can present it. Thanks, Prachit, Dr. Lata, and the speakers I was hearing today, Jan Hicks, Prenderson, and I think they're wonderful. And as usual, Dr. Sima, my colleague, has been working full time in these things. I'll take 10 minutes time. So I have actually shared the link in the chat. You can look at that content. Everything is there in the content, and also more importantly, give an idea that what maybe country wants to do in India. The reason I'm telling you this thing is that look at the disparity of workforce. I think Jan actually mentioned about the challenges in Australia is facing. And every month, maybe I become referring to 2 or 3 my resident in psychiatry who goes to Australia, look at condition in India itself. So this is what we're looking at this point of time. And I think I work in full-time addiction specialist. So my focus is most on addictive disorders. And any innovation comes with some pain that kicks you. And obviously in a public hospital that you work here, often in each OPD, I see many people throwing a seizures or delirium tremens, and they come from very far place of country. Many pay from their own pocket. They don't have resources to go to private corporate hospitals. And often I wonder if this gentleman who comes from, let's say, 100 kilometers from Bangalore, he have given 10 to 20 milligram of diazepam tablet or 2 to 4 milligram of lorazepam, whole delirium tremens could have been stopped. And patient doesn't have to come with a hyperactive delirium tremens to emergency and sort of have passed through the pain of a public hospital. So that is where actually I started thinking 10 years back, is something can be done. Probably my mentor, Professor Pratima, who was officer in charge and currently director, actually motivated me to take this up a little further. So that is where sort of we thought, we used to do the capacity building as you work in any institute in country in India, you are obliged to do this part, but then we used to go to district hospitals and train 10, 20 peoples. But we thought, can you make it a little larger? And there's a point of time I went to US and sort of spent some time with ECHO, and that's where the thing started. So that is the time when India just started having 4G. I'm telling about 2012, 2010, 2012, 2013. 2012, 2013, yes. So ECHO stands for Extension of Community Healthcare Outcome. It's very, in a simple way, it's like a virtual round that you conduct in a group of healthcare providers. So maybe I'll just play a little clip. You can get.
And on examination, at the time was 180, blood pressure was 140 by 100. He was very agitated. Tremor was there, restless. He had tachycardia and history of seizure. There was hallucination for 2 days. And his audit is.
I will tell him, is audible or I don't not sure, but what is happening here? A doctor from Bihar. Bihar is one of the remote part of the country, and Sitamahi district of Bihar actually discussing a scenario where a person has developed withdrawal symptom following stoppage of alcohol, and he's trending to Niman's hub. It's a hub and spoke. You can see Dr. Jayant, who is my colleague now as faculty, actually taking this case up and asking how to manage this case. Prachit, is it audible or it's a lot of, I'll switch on now.
Score was at the time of admission 30 and Shiva's
audible,
score was
sir.
26.
Okay, sir.
So I treated with lorazepam 2 milligram 1 1 plus 2 and thiamine 100 mg twice daily.
So next, what is happening around that, and the Dr. Jayant is guiding him. Can you assess the withdrawal symptom by using a SIVA? SIVA stands for a Clinical Institute Withdrawal Scale. And remember, the doctor who is treating has never treated alcohol in his practice. He's a general physician in a remote place country. So for him to decide what I should give next needs some degree of assessment, and that's why he's doing it. And
and haloperidol 0.2 milligram tablet. But in the evening of 4 or 5 16 haloperidol injection start में दे देने के लिए, but I gave him lorazepam 2 milligram injection. Then he became quiet.
It is a case of alcohol dependence, and he is presented with delirium tremens. And Dr. Mahesh is.
Right. So what is happening that a doctor who has never seen a case of delirium tremens started managing the symptom from a place like Bihar. And then this goes every week. It's not a one-time program, every week. So it's like mentoring. I always tell my students that, look, medicine is a craftsmanship. You have to do craftsman, you observe, watch, and this is how I learned medicine. I observe my faculty, my sort of teachers, how they're discussing, how they're doing it. And in this process of tele-mentoring, you become, make them over the time of 6 or 8 months of every week discussion of cases. They become as good as me, working as a specialist, where they become, where they work in their community, they sort of become a quasi-specialist. So this is what it works normally. It's a best practices, wisdom plus evidence, co-management of the remote patients, deep learning, and obviously some database. So this is what we did, and this last slide before I go to next part. So we realized that we did publish this paper that 85% of the alcoholic disorder were provided best care by the district non-specialist medical officer who was connected to ECHO program. And we saw that it is feasible, it's doable, but you need many hubs to come up in India. India is a big country, healthy population. So I'll not go in detail about that part, but then at that point of time, I've not mentioned here that we proposed to the ministry to develop a digital academy, and that's how it came out. Okay, now any innovation stays around 10 years. This normally happens, you can see, or quote, or any innovation. 2013, we started this ECHO program. It became a digital academy and runs it. But then we realized that, with so many healthcare providers, how do you go to do this live program? Because you are a full-time faculty here, you would give time for patients. That is the reason we came with a small mobile app. Again, it's very sort of developed by our small team that we have, none of us a tech person. So this is on behalf of the ministry. The app, it's a more a guidance tool. We're not doing many revisions, and you can see the screens here. So in section 1 talks about how to ask question, what assess you do. It's for healthcare provider, not for the patients. It's not directed to the patients. How do you assist them in recovery, and when do you want to refer the people? Section 2 talks about individual drug. The primary focus here in this app is mostly alcohol, because there's a commonest problem in the country. Tobacco, obviously, this is again a public health problem. We have improvised the app to further to opioids, because you realize that many residents are using this app for Suboxone or buprenorphine or methadone treatment. Cannabis is again a problem. So this app is available free for App Store and Play Store across countries. Then at the last part, you realize that we would add a live chat. At least a doctor can speak to doctor. Doctor means I'm telling you, any doctor or any healthcare provider can talk to us once a week, wherever we will time, and look at the feasibility of the sort of having their doubts clear and having to manage the cases. Okay, these are the few screenshot and then other addictions. Right, there's some library, there's some rating scale. And today morning, actually, somebody asked me, can you have a Hindi version of audit? Audit is there. Again, India has a multi-language problem. So I was thinking about how to get it go ahead. Fortunately, this app, I mean, I'm not only a very sort of very popular app, but at least 130 countries has been using the app now, and the different analytics ones. Okay, the last slide. The point is that I think Dr. Sima did mention about self-assessment, low threshold intervention. I'm talking about addiction and stratification of severity. I think the challenge in addiction is that how do you sort of train the person where a person is comfortable to talk to another person and other people with addictive disorder more of without any stigma. But I think after listening to Yannick's presentation, maybe the future is humanoid AI. You need AI definitely, but some human expertise is important for the scalability. Okay, this is the last one we tried. I mean, again, we should still try stage. Anybody, when is any audience who's from Odisha, where my colleague Akita and Tejdeepik has been working on this, we realize that, there is a disparity in digital care. I know all the English language. I know I can have a beautiful interaction with smartphone. I can do it. Can we have something in Oriya? This is actually it translates into a youth Odia app where it's a soft lending of the youth to the platform, and they can do some self-assessment, something. Then if they get some self-assessment tips, or they call telemanas, I think which Dr. Srikant is involved and directly and top is written. So maybe the future is again using these regional languages and look at the backend analytics. Is it possible? Thank you very much. You can download all the slides from there and chat. I'll stop here.
Thank you very much, Dr. Prabhat Chand. I think that was again, we've seen yet another excellent presentation today with a focus on addiction treatment. And I think the focus on treatment through capacity building as the only way to scale, that you need more and more non-specialists, as you put it, who can actually help in this. And, things like your ECHO program and the subtle but important difference between tele-mentoring and telemedicine and how that can help scale. I think these are very insightful. And the mobile app, the fact that you've been able to scale it up with, as you put it, with very little publicity and stuff is impressive. And I think fact that now it's being extended more and more to even common users, not just health workers. And that automatically, like you said, brings up the whole issue of local languages. And to make anything meaningful in India, you have to cover, I don't know, 12, 16, 18 languages before it's fully effective. But this is a great step in that direction. And thank you for these insights and for good to see this kind of work all across the country. Thank you very much. Dr. Prachet, I think we have come to the end of this part. And please take over.
Yes, sir. Thank you, sir. So thank you, Prabhat, sir, for that insightful talk on the use of apps in supporting addiction prevention and recovery, and also for highlighting the role of capacity building in mental health. And you, of course, shed light on various innovative ways through which we can extend care and empower the individuals. So thank you for that. So I can see one question in the chat box, which I guess Professor Ian has already addressed. So
yeah, I'd like to take that one up. This issue of engagement is a huge issue for all of these new tools. And the one that we've been working on here with people with lived experience and non-professionals are saying, so not getting more health professionals, but non-professionals, because is the role of a digital navigator, a term that John Touros at Harvard sort of coined in this area. And it goes to the second presentation, also with people with more severe problems, the whole spectrum, having people who really assist with the use of technology, getting the technology bit and assisting people to use it to have a better interaction with the systems themselves if they're self-care, but also with services. So I think this is a huge issue, completely unassisted and unguided and just apps out in the world have very low engagement, so the credibility. And so this has become a big issue for us about the development of the digital navigator type role, particularly in settings where there's a lack of professionals, and assisting with the quality of information in and in the way the services respond to that. And I think in those areas where we're all desperately short of health professionals, we need to think differently. And this allows communities, families, other people, volunteers, others, and people who just can use technology. I don't know about you, but my kids help me with my technology all the time, like to stay in it, to use it, to understand how to do it better effectively. And I think this way, I think also the personalization of tools through AI more that that you feel you're in a conversation that's much more focused on you and not with preset algorithmic rules also has the potential to increase engagement.
Thank you. Thank you so much for that. So we have another question in the chat box asked by Sharon. So it's open to all our distinguished speakers. How can we make these digital applications accessible to users with low digital literacy?
Okay, can I take this up?
Yes, please, sir.
I think, I mean, first of all, Sidin, thank you very much. I mean, this is what I struggle every day in my OPD. And I mean, at least the Nuance OPD is a public OPD, and 70 to 80% people have very, sort of, we did a small sort of, I mean, ask my staff, how many patients that comes today has a smartphone in the OPD I'm talking about. And we found some a month back, it's 4 out of 10. So, but then when you ask, do your son has a smartphone, daughter has a smartphone? Yes. So the question is obviously when I see a person alcohol dependent, there's a 50-40, maybe they may not be digital savvy, but then I think, as Ian mentioned, we have to take the whole system into the place. I mean, but then to wait till digital literacy comes and everybody has a smartphone and start the program may not be a good solution. Well, I'm telling simple example. We started a Relax Friends and sort of phone call, very simple phone call. Each person comes to this public OPD of Nimans, people with addicted disorder. If they drop the follow-up, somebody will call by basic phone. And we saw that by this much intervention 10 years back, 80% people can come back to your system. So sometimes a small low threshold intervention without decreasing the diesel load a little lesser, maybe also very acceptable. But I think you have to figure it out. I don't think anybody's answer, but we should go ahead and do it. I was looking at the Odisha at that point of time, 70 to 80% of people had actually smartphone in Odisha, which is a relatively poor state. And the data being much cheaper now, and UPI is a big thing for India now. The money transaction through UPI, so you have to have a phone to pay through UPI. I think this is changing very fast. Thank you.
Thank you, sir.
Just
yes, ma'am.
may I
Please,
say something?
please add,
Yeah.
ma'am. Yeah.
Actually, just continuing with both these questions and the responses given by our colleagues. Yes, I think engagement, what is very important is personalization or customization to the extent possible. Professor Yan spoke a lot about it. Interactivity in the digital tools, the kind of tools that we see, a bulk of them sometimes have very little interactivity that would also result in high attrition and dropout. And human connect to the extent feasible, it could range from minimal to moderate, but human connect either via chat, synchronous, asynchronous, via telephone call, periodically, we have found that this can really improve adherence, or it could be in a full-fledged blended format. But even before the blended format, there could be small ways of nudging people to comply through some level of human connect. So that is one thing. There was this sub question on long-term outcomes. Obviously, the answer would depend on what the app is trying to achieve. To just go back to the examples I was citing, if an app is attempting to improve help seeking in a person, then if the person after usage for 1 week is able to realize that he or she needs help and is able to reach out for mainstream help, then that outcome is achieved for that individual. If it is about depression, then it's about outcomes that we may look into which are relevant for that. From a systemic point of view, public health point of view, impact would be obviously more in terms of what is the uptake in a given setting where it is integrated with mainstream services, uptake by the health professionals as well as by the clients, and how much these are sustainable. So that's about longer term. And I think the second question again is I go back to this idea that yes, digital literacy in general needs to be improved through various means. How we improve health literacy in general, campaigns for improving digital health literacy, particularly for mental health apps, because there is a mushrooming of apps, and what to use, what not to use, when to rely on becomes a very key question. In terms of navigating through an app per se, what we have found that it really helps to sit down either online and offline and have a conversation with the client as to how they can navigate the app, in addition to maybe having some very easy to understand videos about how this app can be utilized. So Human Connect again is something that might help in bridging this gap. Thank you.
Thank you, ma'am. Thank you for those insights. So with that, we've come to the end of session one. So let me take this opportunity to thank our chairperson, Professor Srikanth. Thank you, sir, for sharing your wisdom with us. And I would like to thank all our distinguished speakers. Professor Ian Hickey, thank you, sir, for joining us all the way from Sydney. So it was such a pleasure to have you. Dr. Seema Mehrotra and Dr. Prabhat Chand for sharing your valuable knowledge with us. Thank you. So now let's move on to the next session, and I request Dr. Lata to take over here.
Thank you, Prachit. So I welcome all of you for the session 2, that is on digital tools and interventions for mental health. And we have 3 speakers for this session. And I would like to welcome Dr. Sendil Amudan, the first speaker for this session. So Dr. Sendil will actually cover on the topic, that is the importance of digital tools and interventions. So Dr. Sendil Amudan is currently the professor and head of the Department of Epidemiology at NIMHANS, Bangalore, with over 18 years of distinguished academic, professional, and research experience in public health and neuropsychiatry. Sir has pioneered innovative mental health care delivery models, including IRIS for ASHAs, featured at BMJ. His work has advanced mental health literacy locally and globally, and for the past 5 years, he has focused on technology addiction in school settings. And he has collaborated widely with various stakeholders, including expert committees, research projects, and also technical reports. So, sir has led and co-led various national and international projects, authored 60 plus peer-reviewed publications, including significant publications in Lancet Psychiatry and International Journal of Epidemiology. And some key awards include BMJ Award South Asia in the year 2016, ICMR Professor B.C. Srivastava Foundation Award in 2020, and Dr. Abhaya Indrayan Award 2022. So we are delighted and privileged to have you, sir, and over to you.
Thank you, ma'am, for the introductions. Thank you, ma'am. And without taking much time, I will share my presentation. Just tell me sharing. Slides are visible, ma'am? My slides are visible?
Not yet, sir. No.
Visible, sir. It's visible, I think.
These are visible, Professor Sardar.
A very good morning
Yes.
to all. Today I'll be talking from the public health perspectives on digital tools and interventions, why and for what they are needed. So we all know that the burden of mental disorders has increased over the past 3 decades. In 2019, and currently also mental disorders accounted for approximately 5% of global DALIs, with depression, anxiety being the most prevalent things. That also exists a huge treatment gap with a range from 76 to 85%, more so in the low and middle income countries and more in the rural regions. We need to acknowledge that there is a shortage of trained professionals and stigma in country like ours, which prevents the timely care. And there is also an under-resourced mental health system that limits yearly identifications, follow-up, continuity of care, and outreach. While these statistics highlight the global challenges or the global burden, the burden does not appear to be uniform. And when we look at the age groups, the different age groups experience unique stresses, risks, and barriers, many of which are shaped by how they use tools and how they are excluded from the digital tools as well. We also need to acknowledge that there are emerging issues, and these issues does not appear to occur uniform across the age groups, across the life course. They also vary. They also vary, ranging from anxiety, depression, technology addictions in children and adolescents, to work-related stress, to digital overload in adolescents, to social isolations, to digital exclusions in older adults. While these differences actually matters, which highlights that one size fit all digital interventions would not be possible. Indeed, we need to. There is a need for tailored age-sensitive interventions that bridge the treatment gap, overcome stigma, and also provide care in a ways that are accessible, engaging, and sustainable to different age groups. Now, I will also take you through the evidences that we have found with related to these emerging issues across the life course. The study that we have conducted in Kolar in pre-COVID in the year 2019 to 18 highlighted that nearly 10% of 11% of the school-going adolescents were found to have problematic technology use, predominantly in the form of addictions, with video game and with phone addictions and video game being the major contributors. The study also highlighted the gender differentials and also the difference with regard to urban and rural. It is important to highlight that though the usage is very less in rural regions, the addiction component was predominantly higher in the rural adolescents, particularly with regard to video game and the phone addictions. With regard to gender, both usage as well as addictions were found to be greater in boys and girls. This is the situation that we had in pre-COVID era. In after COVID during year 2022 and 23, we have conducted the study, though in a different setting. We found that the problem has actually increased 3 times higher than what it was there in the pre-COVID period. Technology addictions were found to be around 35.4. We anticipate that because it was done in the purely urban setting, if we have the rural setting, I think the problem would have been more as well. So it clearly shows that nearly for every 3 students, there will be 1 student who will be having a problem with technology addictions. A subsequent regression analysis found that social networking and entertainment usage of technology has found to be associated with increased addictions among adolescents. We also explored the reasons of the different technology used to understand the context in which these problems arises. The narratives from the teachers highlighted several academic and non-academic challenges. The teachers also highlighted several barriers and facilitators for healthy technology use and placed the huge responsibility to the parent, and they highlighted that lack of parental consent and parental awareness regarding the technology use has been highlighted as a major barriers for all these problems. And they all have pitched for creating a healthy digital environment. The narratives from the students highlighted the patterns and the purpose of technology use, which says that gratifications, entertainment, and social networking were the predominant use for the technology, with academic purpose being the least common use of technology. Though the students have perceived the consequences of excessive technology use related to adverse effects on physical health, mental health, social life, and school health, they could not come out of these problems, and they acknowledge that whenever they end up using technology frequently, they end up using more use than less. More importantly, they were afraid to approach the teachers or the responsible adults because of the stigma and the fear that attached with the technology use. The other problem that comes that we have studied in the recent study that we have conducted in the last year, we found that loneliness is a very important problem, where nearly 18% of the adolescents were found to have high to moderate degree of loneliness. We also found that loneliness leads to technology use, and technology use also leads to kind of loneliness, a kind of virtual loneliness that happens things. So these are the issues that we need to consider when we talk about the issues in adolescence, apart from the routine mental problems like anxiety and depression as well. Now, coming to digital addictions in adults, the recent meta-analysis paper that we have published, we have found that internet addictions in any form was found to be around 25%. Nearly 1/4 of the adults were found to have one or other forms of technology addictions among those who are using technologies. So this is only the internet addictions. The problem is going to be very high when we talk about the game addictions as well as the smartphone addictions. Now, coming to the use of digital in elder adults, though it comes with the benefits like enhancing physical, mental, and cognitive functioning and supporting health management, promoting autonomy and general functions, it also comes with the burden or challenges where digital exclusions due to non-user-friendly platforms and low literacy, technology-related anxiety, risk of fraud, misinformation, and psychological distress affecting the overall well-being is also documented. So what is the way forward? We all now know that there is an increasing use of digital platforms for communications, learning, work, and health. At the same time, it is associated with concurrent risk and burden, ranging from anxiety, burnout, social isolations, and digital exclusions. Leveraging digital tools thoughtfully becomes crucial to maximize mental health benefits, but at the same time, we need to minimize the technology-related harms. So the digital tools needs to enhance access, early detections, monitoring, and personalized interventions across all groups. And the findings, the evidences actually highlights the need for thoughtful, life course sensitive interventions that must balance potential benefits with risk, promote inclusions, usability, and sustained engagement. I will stop at this point. I'll leave it for further discussions on this. So the take-home message here is the digital tools needs to be thoughtfully used thoughtfully across the life course to enhance mental health, provide personalized and social support, and minimize the risk of digital overload and exclusions. Thank you.
Thank you, sir. Thank you very much for highlighting on the important aspect, that is how to bring the balance. Because right now we are in the era of too much of accessibility, where like actually we are trying to gain accessibility at one level, and at the same time we are also struggling how to maintain that balance. And thank you for those insights into your research which has been done on internet addiction in the school settings. So I would request the participants to share your questions on the chat, and next we would move on with the next speaker for the session, that is Mr. Jomi T. Jose. Mr. Jomi holds a master's degree in counseling psychology from Christ University, Bangalore. He has previously worked as a counselor at the de-addiction center at the National Tobacco Quitline Services, NIMHANS, and he currently works as a program manager at NIMHANS for the Microsoft funded project that is empowering communities through digital psychological intervention for mental health care, where he oversees the development of digital tools and conducts outreach and awareness programs to support mental health in communities and institutions. So over to you. If you can please unmute. Organizers, can you please unmute Mr. Jomi? Yeah.
Yes, ma'am. Thank you for that wonderful introduction. Just let me know once the screen is visible to all of you.
Yes.
You're muted, Mr. Jomi.
Please unmute. The central team, I think.
Am I audible now?
Yeah.
Okay. So from today's earlier talks, we saw how digital platforms can make support more accessible, reduce stigma, and encourage people to seek help when they need it. Our attempt has been to work towards creating a digital mental hub, a space where multiple initiatives come together to support people at different stages of their mental well-being journey. This work is made possible through the massive support of agencies like ICMR, Microsoft, as well as our technology partner, Triple IT Bangalore. Today, we will be talking about two such platforms, our mobile application MindNotes, along with our peer support forum, Let's Talk Live. Before we begin, we'd like to share an intro video to our mobile application MindNotes. Yeah. Right, so we saw a quick intro to the MindNotes mobile application. This is the QR code for everybody present here. You can take a screenshot of this QR code and you can access the MindNotes application for both the Play Store and the iOS App Store. So before we begin, what is MindNotes, right? MindNotes is a free mental health app from Nimhans. It has been designed by a team of mental health professionals and public health experts together with IIIT Bangalore. This app is meant for individuals who might be experiencing distress or common mental health concerns, but who are unsure about reaching out for professional help. The goals of MindNotes, as Dr. Seema pointed out, include awareness, to enhance awareness about mental health, to address barriers that often prevent people from seeking help, and to provide a personal toolkit for self-care and everyday well-being. Before we move forward, we will show a video outlining all the different sections of the MindNotes app so that it's better to understand what all sections are on the MindNotes app. Can you let me know if the audio is audible to all of you?
Audio is not audible, Yomi, for the
Audio
video.
is not audible. Okay.
Video of the audio is not audible, sir.
Sure. I'll Yes, as we saw that MindNotes has 6 core sections. So if you were to download the app, this is what the mobile screen on your phone would look like, right? MindNotes has 6 key features or key sections. There's a self-discovery section, which has quizzes and story-based questions to gain insight into mental health concerns. We have the breaking barriers section, which has tools to help users recognize and overcome obstacles, which become a barrier in them seeking professional help. We have the self-help toolkit, which has 7 modules, including techniques for managing worry, self-criticism, anger, and social anxiety. Along with that, we have the coping with crisis section, which has immediate strategies for emotional crisis, including a list of all the currently available helpline numbers in the country. We have the professional connect section, wherein a user can reach out to us, where they can ask any queries related to reaching out to professional help that they may be facing. Along with that, we have a little act section wherein a user can choose to explore small activities that they can do to take care of their well-being. This list is updated every month. Currently, the impact of the MindNotes app has been so much that it has been installed on more than 2 lakh devices. In just this year alone, we've had over 42,000 new registered users. Through the Professional Connect section, we have received and addressed over 800 concerns directly from the users. The range of concerns is wide, from exam stress, relationship challenges, grief, and loneliness to concerns about bullying, queries on affordable counseling, and dilemmas about seeking professional help. Currently, the MindNotes app is available in English and Kannada, and we are excited to share that a Hindi version will be launching this September. For us, these numbers are not just statistics. Each number represents someone who has taken a small step in their well-being journey, and that is exactly what MindNotes is here for. To sum up, MindNotes is a free, accessible, and evidence-informed tool created by NIMHANS to support individuals in their mental wellness journey. Whether someone is curious about their own mental health, facing barriers to seeking help, or simply looking for small ways to take care of themselves, MindNotes provides a safe space to start. Our hope is that more people will explore these digital tools, use them, and share them within their communities so that mental health conversations become as natural as talking about physical health. Thank you.
Thank you very much, Mr. Jomi, for highlighting the important features of the MindNotes app and also taking us through the video. I think definitely we have progressed in terms of catering to various languages, and also we are happy that we will be having the Hindi version soon. So I invite any questions, comments from the participants, and meanwhile I would like to invite our third speaker for today, Mr. Abhishek Karisiddhimat, who is a psychologist and a psychosocial consultant with a master's in industrial or organizational psychology and training and an additional training in community mental health. He is a senior project research scientist currently at the ICMR Center for Advanced Research in Digital Interventions for Mental Health Care, located at NIMHANS, and which is actually looking at studies on indigenous digital tools. His interests span worker well-being, youth mental health, scalable digital self-help, and also he has worked previously on various behavioral insights and managed Microsoft-funded projects at NIMHANS. So welcome, Mr. Abhishek, and happy to have you with us today. And I would like to invite you for today's session.
Thank you, ma'am. Thank you for the introduction and welcome. I'll just present the screen. Yeah.
Yeah. Your audio is mute. If you can please unmute.
I guess once we present, it's muting us again. Just a second.
The central team, can you please enable?
I guess I'm audible now, ma'am.
Yes.
Yes. Yeah, now can you please unmute them?
Akash, can you please unmute?
Akash or Ashish or Divya, if you can please help us in that.
Yes, sir. Just a second.
Yeah, thank you.
Akash, can you please check if I'm able to present with me being unmuted?
I think
Yes.
he's working, he's
Yeah,
looking
yeah.
into it.
Now you are unmute.
Okay.
Yes,
Is the
Abhishek.
screen visible and am I audible?
Yes.
Okay, thank you, ma'am. Thank you, tech team. So, like Jomi has just described and went through how uh, Mind Notes as an application can be used for anybody. I am here to introduce another platform from Nimhans. It's called Let's Talk Live Peer Support Forum. So before I begin, there's a screen I've put on the which we can see. There's a QR code. You can use the same. A message with the links will also be shared in the chat box soon, right after the session. So what is Let's Talk Live Peer Support Forum? This is a forum that is an online peer support forum wherein it is moderated by mental health experts here at NIMHANS, and also the volunteers who would be responding are also somebody who are being trained here in-house at NIMHANS. This provides youth with a safe place where they can actually post questions, their queries, their thoughts, their concerns while being anonymous, and they can connect with these trained peer support volunteers who are, like said, they're also going to be trained here at NIMHANS. And the users can expect to receive empathetic support and also suggestion for what's going on their mind. This is a forum that is created for youth to be able to talk to each other and be able to support each other in terms of mental health and general well-being. Now, to sign up, you will have to create an anonymous account on the forum, the link for which will also be shared. There's a QR on each of the slide that you can use. You will be able to explore the forum, read what others have shared, their posts, their thoughts, their feelings, and the questions that they might have asked on the forum. And you will be receiving support from a trained peer support volunteer within 48 hours. Now, to tell you the impact so far, it's been almost just about a year that the forum is live. It is redesigned and it is made available as a web page and also as a mobile application recently. The forum has already had more than 41,000 visitors who have probably went through the forum, have seen the responses on the forum, passive users, and also we have registered users. Since the last 1 year alone, we have 1100 plus users who have registered on the forum, and we've received 173 plus posts, queries that have been posted on this forum. One thing that we've noted that 84% of the users currently are in the age group of 18 to 22. Now, what this forum is not, this forum is meant to support individuals who might ask questions and want to know more about it and want to get some sort of, want to be heard as an individual by their fellow peers. Here, the volunteers are supporting, but it is not a replacement for mental health support professionally. While it can be supplementary and complementary to other forms of treatment as and when needed, it is something that you can use for your general well-being as a student and a youth. It's one of those tools that can be a part of your collective, well-being toolkit, or if you have certain things that you've planned for your well-being, this could be one of that, and that can help you in your well-being journey. Now, we want to remind you that mental health is fundamental, and prioritizing your mental health is key to make sure that you're able to maintain your overall well-being. Now, this tool is already live and is available as an app for Android users and as a web forum for users who use mobile phones as well as on laptops. Now, some snapshots from this platform, if you can see, the first snapshot is showing how a particular post is visible on the forum. You'll be able to see certain tags like, general concern or any specific concern. There are tagging options, so you know what kind of posts are being posted. And at a glimpse, you'll be able to see and be able to explore certain posts that might be something that you would want to read and maybe similar to the kind of experiences that you might be facing in your life at that moment. Along with that, there are a couple of snapshots from just the introductory portion of the web forum, and you can see there are some in the fourth snapshot. You can also see how you can actually respond and engage and communicate how you feel through that particular post. You can say if you feel that this is something that sounds tough and you want to tell the user that they're not alone, you can do that. You can say if you're able to relate to that particular post, and if you're able to make them feel supported, you can use those icons there to engage with the post as well. Now, another initiative alongside the other two apps which are already available on the public platforms is the upcoming Pushti a mobile application and web forum. PushD, the current version is already live as a web page, but it has been redesigned, and probably in a month's time we will be publishing it online for people to use. It will be available both as a mobile application and as a web forum. Now there are some snapshots of the upcoming forum, which is going to be redesigned and published for public use. Now, PUSH-D is an acronym for Practice and Use Self-Help for Depression, like Dr. Seema has already presented in her in her session before. And this is a self-help program which has been designed for individuals who may be experiencing mild to moderate symptoms of depression. While it does include evidence-based approaches and interventions that can help in managing depressive symptoms, it is also a structured self-care program, which is supposed to help and empower individuals by offering them space to learn, to also be able to strengthen and practice psychological skills that can be helpful in managing depressive symptoms. So this platform is also going to be soon available for users. So what we want to recommend everyone who's attending today is that you've been given a small introduction about these platforms and the evidence-based, the empirical studies that have been conducted over these platforms and by the users of these platforms at NIMHANS. We want to again emphasize that while we want to make sure that people are aware of such platforms exist, we also want you to go ahead and support in promoting it. In the sense, if you know anybody who's asking for some sort of support and they feel like they want to try something out for their well-being, these are platforms that you can suggest, and some of them they can practically use as well. And these are easy to use, user friendly, and since they are from NIMHANS, developed at NIMHANS, you can also be assured of the level of data privacy policies that have been followed for these platforms. So any more doubts, definitely please reach out to us. The links will be provided to you right after the space, where you can go visit, download, probably read more about these platforms. And if you have any questions, we're open to take them. Thank you so much.
Thank you very much, Abhishek, for that overview on the two important applications, that is the Let's Talk Live and the upcoming PushD platform. So we can have the round of questions, comments from the participants. I'll just look into the... Okay, already sir has answered one query, I think. Sir, would you like to add anything, Sendil sir, on the query by Dr. Rubel?
Yeah, I would like to reiterate for those who have not seen the chat.
Yes, sir.
The question about the question that Dr. Rubel has asked is, can I please know in experience what are some effective ways to help adolescents balance their use of educational technology with offline activities? So actually, it requires a multi-level approach for it to work best, starting from the individual level, peer level, school teachers, and also the parents. Starting at the individual level, the student should be empowered to know the health use of technology to the routine curricular training, and there should also be some strategies to promote physical activity as well, because as things get shifted, at least there will be responsible and the healthy use of technology as well. And there is also the teacher should also be empowered to see that how they can promote the healthy use of technology in the school children's. More importantly, the huge gap that we found in our experience is that there is no parental support or the monitoring about the use of technology when they spend most of the time at homes. So there should be a collaboration that needs to be made with the parents, and the parents also should be empowered to see that how they can support their children for healthy use of technology. Unless all these things are addressed, we won't get the maximum outcomes on the things that has been discussed here. So it requires a multi-level approach.
Thank you, sir. Thank you very much. So I would just like to ask Abhishek on the PushD platform.
Yes, ma'am.
Yeah, actually, like it was as part of the trial where Dr. Seema ma'am has clearly mentioned that the feedback and the complaints and various things were actually very good. And in terms of limitations also, ma'am clearly specified that it is not like a replacement, and it is like a supplement or complement. So definitely in terms of PushD and PushD plus interventions, So if you can just like highlight on the important aspects with respect to the complaints and the feedback and the user friendliness, so that the people who would like to use will actually have more clarity.
Maybe Dr. Lata, I can take this.
Yeah, sure, ma'am.
Just here.
Sorry,
Yeah,
I
so
could not ask that time.
yeah, no
Yeah.
issues. Yeah, thank you for that. So we do, as I had mentioned, we have completed 2 studies on that. One as a completely unguided version, minimally guided version for community sample, and another one on a clinical sample, which blends push-T with, therapist intervention of 4 to 6 sessions. So both these formats, it has been tested, but as a single group design. In CAR study, we are further looking at a randomized control design for which we want to move ahead, as well as an implementation study in CDMHP settings. So these are about the studies. The initial version had very, very limited funding, so it was not as user-friendly as it could have been. So currently, with Microsoft funding support and IIIT as tech partner, we are redesigning it and we'll be relaunching it soon. I think Jomi mentioned in about a month or maximum 1 month and a half, we will have both a redesigned web-based version as well as a mobile app version. And we'll surely share that with the NMHS team once that is in place for further utilization. I think Dr. Shrikant, if he's here, he could tell us more about when does he think we would be able to launch Push-T.
Yeah, thank you, Dr. Seema. I think we're very close. I think like you mentioned, it should happen over the next month. We are in the last stages, more trying to work out some deployment and other logistics. I think most of the testing is done, and yeah, about a month sounds right. Maybe sooner if we can, push everything.
So the main change has been in UI UX and the backend, updating the codes and so on.
Yeah.
Thank you.
While preserving most of the key functionality of the existing thing. So it's very similar, but new look and feel.
And just one thing to add to that for the professionals who are here in the forum, that we would also be having a facility whereas there is a dashboard wherein professionals can register themselves and they can register their own clients and they can observe the progress that the client is making on Push-T app. So that will be very useful for the professional community themselves to become part of this whole process if they want to implement a blended intervention. So we will have a dashboard and a system where professionals can enroll themselves as well as their clients. So that's something I wanted to just highlight. Yeah. Thank you.
Thank you, ma'am. Thank you very much. For all the viewers, there are links for all these applications which is provided on the chat. And we have a question by Dr. Sharmita Krishnamurthy to all the speakers. On one hand, there is growing concern about digital overuse and addiction, especially among young people. On the other hand, we are increasingly turning to digital platforms and apps to deliver mental health care. So how do we reconcile this paradox, promoting digital tools for well-being while also safeguarding against their potential harms? Ma'am, you would like to take?
Yeah, sure. So yeah, that's a very, very critical question. Thank you, Sharmila ji, for posing that. Yes, we need to strike a balance between the two, but we could also utilize the digital platforms that we recommend. We utilize those platforms to encourage healthy use itself, because it's a digital pathway that is used very often by youth and young adults. And we could use that as a channel to promote messages regarding healthy use of technology. That will be one. And secondly, we can try and incorporate when we use digital tools for mental health. It's not that people are working on the apps. We nudge them to work outside the app and come back and talk about what they have utilized. For example, one simplest, smallest example will be in Mind Notes, we have little acts. So little acts are things that you can do. We nudge people to do outside the app. Can you do this A, B, C, D, and try to do that more often and come back and record it. So when apps encourage behaviors which are, health promoting outside the app environment, that would be one way to minimize this danger. And thank you for bringing it up. Yes.
Thank you, ma'am. If anybody else would like to add to that question. Okay. So we will take up the next question.
If I can
Yes,
add something.
sure, sir.
Also
Sure,
combine the
sure.
last question that's
Sure.
there's a question on AI chatbots which I was waiting for.
Yeah,
I think there is some overlap in these two, so let me add that. So I think there's no question that I think we should look at digital tools very carefully. They help in certain ways, and if left alone, can cause harm. We should be ready for that. So I think there's both an ethical and ethical, moral, as well as a technical reason to be careful how we use it, right? So I don't see in the near term that AI chatbots can completely independently be let loose in some sense, at least not from, say a professional organization or an ethical organization like Nimmans or somebody like that. There are plenty of AI chatbots available, but they can do harm if they're not, monitored carefully. So I think we have to look for places where AI can help and be very specific about how it can help. Right? What is often referred to is you either make sure there's a human in the loop so that nothing goes out without human moderation, or as Professor Hickey said in the morning, there's AI in the loop. You have a human-based process where you use AI to speed up, amplify, uh, improve productivity, improve efficiency, and so on, but not replace, not completely. So I think that's a given for some time, at least with the current state of technology, especially the LLMs, the large language model spacing, can spout out things that you don't want. So I don't think it is anywhere that far, and definitely adding rural, multi-language, and so on, I think it adds to the complexity. So yes, digital tools have a huge role, but have to be used in very careful, and it's going to take time for that to, I would say, get mainstream in the way we would like. Press and what the big GPT like things can do is a whole different story. That's not mental health care right now.
Thank you, sir. Thank you, ma'am. So next question is by Devjani. While digital tools are now indispensable for treatment focusing on mental health, however, narrative medicine plays a vital role as an essential component of the medical humanities. Is it possible to have a tool specifically focused on narrative medicine, which goes beyond algorithms, providing humanitarian holistic vision of health? Given the context, is there a way to enmesh both to overcome the limitations of each? Also, the question of ethics in maintaining data privacy. And there are specific thoughts and questions, and I would like to add to the speakers. So this is the question. So I think definitely as part of the session, also some of these aspects were covered, covering on the data privacy aspect, even by Dr. Hickey in the beginning, and also later on by Dr. Seema ma'am and team. Anything you would like to include, ma'am? Especially on the narrative aspect. I think mostly it can be linked with the Let's Talk Life model.
I'm not sure. I think the answer lies in the question that has been raised as to the need to, synthesize and combine both. Yeah.
Yes, ma'am. Thank you.
Like I can add on the data privacy part.
Yes, please.
Definitely, it's a question of ethics, and now it's also a question of law in India and many other places. So we have to ensure that these tools protect privacy, to the maximum extent, definitely as required by law from a compliance standpoint, but also by your specific ethics principles that are there. It is an exercise that has to be done during the design and the implementation. There are clear principles that you can follow to ensure that privacy is protected. Very simple things like making sure you collect the minimum data So in a digital tool, for instance, unless you need to, you don't have to collect the phone number or email or something. You just figure out what's exactly needed to deliver the functionality and the service that you're providing. And there are consent at the appropriate places, making sure data is not shared, making sure data is not retained unnecessarily, and so on. So there are some very specific principles that if we follow, and you overlay that with the ethics principles that you have, I think you can do a good job on this. Definitely, it will be required going forward. Now we have the Digital Personal Data Protection Act is already in force, so there is no choice but to comply with this. So I think digital tools will get better that way in terms of privacy. GDPR is a great example where in Europe it's moved very far. So we are also on the same path in India. Thank you.
Thank you, sir. Thank you very much. So there is a question by Hari Gopi. How can illiterates use these apps? I think initially Prabhat sir had actually made a point on how many are actually using a smartphone and how many are not actually using among the visitors within our OPD setting. If any of the speakers would like to add on this, because definitely it is a limitation in terms of language, but I think already regional languages have been tried was one of the answers which we have got so far.
Yeah, I think I posted the response there.
Yes,
Regional
ma'am.
languages is one thing, which is not an easy exercise. We have found that it's an extremely difficult exercise for any complex app with lot of content to be translated in a way that is relatable to the users. Even for Kannada, our journey is still on. English, we have had multiple rounds of iterations, and when we think of other languages, we may need to work harder and more collaboratively with other states. So we hope we should be able to do that to an extent possible. In terms of people who have not had formal education, I had just put down a possibility that more video based content is one, and we are trying, for example, the new Pushti, read it or read aloud or listen to it. Whatever the text is there is a listen to it button, as well as video based content that could partly help those who may not have had formal education and who find it difficult. If it is more text heavy, then obviously it's going to be more complex. So a listening option can be one of the possibilities that we have thought of. And I think
Thank you,
Dr.
ma'am. One last
Manisha,
question
yeah,
on
Dr.
the
Manisha has asked a
certification.
question.
Yeah.
Just to say, very true. Many of our psychiatry, clinical psychology colleagues get asked this question by some of the users, some of the service providers. Please tell me which app can I use? What can I use for it? Or sometimes they are going away. They are not under our direct care. They are traveling, or they are from some other city. There is no access, and they want to know something that they can make use of. And there we become a bit challenged or handicapped, I would say, if we are not fully aware as to what to suggest to clients. So this is a very good point, that we need to include digital mental health literacy and information around what to tell the clients, when they can use, what they can use, and how they can use. And it should become a part and parcel of our curriculum and training. That's a very wonderful suggestion, I thought, more than a question. So yeah, and as part of the Center for Advanced Research, we are coming out with a platform for Indian users where they would be able to see the apps that we have reviewed, gain more information about how to find the right app that they may be looking for. So kind of a repository for end users. This is the next plan after the systematic review work, which has just been completed. So I hope that will also provide some pointers to clinicians as well as consumers of app in terms of which apps are available for what purpose to the Indian users. Thank you so much.
Thank you, ma'am. Thank you, everyone, for such an insightful and fascinating interaction. I think definitely we need to work definitely in the communities and also with the larger teams, so that we get even better answers for a lot of our questions. And thank you, everyone, for actively participating throughout this session, both the sessions on the digital interventions for mental health care. I would request Prachet for the closing remarks.
Thank you, Lata. So yes, of course, as you rightly said, we've had a very intense and active discussion. Even after 2 hours, the enthusiasm is still very much there. So that's really nice to see. So on behalf of our entire organizing team, that is Team National Mental Health Survey 2, I would like to thank our distinguished chairperson, Professor Srikanth, and our speakers, Professor Ian Hickey, Professor Seema Ma'am, Professor Prabhat Professor Sendil Amudan, and our young speakers, Mr. Jomi and Mr. Abhishek, for joining us here and for sharing your wisdom, your experiences. And I'm sure your clear articulation of how digital and tech interventions and technology can be leveraged in mental health care have made this mental health dialogue truly meaningful. So we extend our gratitude to our administration of NIMHANS, particularly our director, Dr. Pratima Murthy, for her unstinted support and guidance. So I would like to thank Dr. Girish Rao, the PI Epidemiology of National Mental Health Survey 2, for his dynamic leadership in organizing this initiative of mental health dialogue known as MHD in short. And it's really amazing that we've reached double digits now. We have finished 10 sessions, so that's commendable. I thank Dr. Lata for joining me in moderating today's program. I would like to thank our entire team of state coordinators without whom this program wouldn't have been possible, particularly Dr. Akash, Ashish, and Divya Bharti, who were there in the forefront and who were instrumental in carrying out today's program, and our IT team for the backend support. And of course, there are many more from Team NMHS2 who have worked behind the scenes. So kindly pardon me if I've missed out anybody. And thank you all for being a wonderful audience, for joining us in today's mental health dialogue on digital applications for mental health and well-being. So let us carry these insights forward and build further equitable mental health solutions. So we'll meet you again after 2 months for Mental Health Dialogue 11. So before we break, let's have a group selfie. So I request all of you to please turn your video on, and I request Akash or Ashish to please do the needful.
Yes, sir, sure.
It's done.
Yes, sir.
Thank you. Thank you all once again, and have a good day. See you.
Thank you very much.